Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. My name is Noah Mandel, and I'm a resident physiotherapist from Toronto, Canada. I created this podcast to provide you with educational content, not medical advice. Please seek advice from a qualified healthcare professional if you are currently dealing with a health-related concern. If you enjoyed the podcast, please consider leaving a review. I would deeply appreciate it, and you would also be doing your part in helping the podcast grow so that we could provide this information to more and more people. Hi everyone, thanks for listening in again. I appreciate all of you who have been listening to all the episodes and following along so far. I really appreciate it. All right, so today I have Faraz Sethi on the podcast. Faraz is a physiotherapist from the UK with about 18 years of experience. He has a special interest in the foot and ankle, which we discuss in great detail today. We essentially break down the foot in different parts and discuss differential diagnoses, how you diagnose those things, and how we would go about treating them. On top of that, we also discuss just our general approach and philosophies when it comes to physiotherapy. In Instagram direct messages, Faraz and I are constantly making fun of each other, so you might enjoy a little bit of good banter on this episode. I hope it's enjoyable for you. I had a really good time talking to Faraz. He's always just a really good person to talk to, and he's a wealth of knowledge as well. So without further ado, I hope you enjoy. I'm going to make fun of you a bit too, probably.
Please. Okay. No bow tie today.
Yeah, thank you for not wearing the bow tie. I appreciate it. Faraz, you have about 80 years of wisdom at this point, so I'm very eager to pick your brain, get some sage old wisdom from you. So thank you very much.
Let's get it right first. It's 85, my friend.
Okay, my bad. My notes were wrong here. I'm sorry. I am excited to pick your brain, though. So the plan today was to get into all things related to the foot and ankle, as that is your specialty. But before we do that, let's get into a little bit of an introduction. So who are you? What do you enjoy to do? And give us a little bit of a background as to what you actually do professionally as well.
Sure. Well, thank you first and foremost for having me on your wonderful podcast. I've listened to a few of the episodes, and it's great to be here talking to you today. My name is Faraz, and people know me as the Faraz Old Physio on Instagram. I have a keen interest in foot and ankle. I wouldn't say I'm a specialist, because obviously we're still learning every single day. So I'm far from a specialist, but I do have a keen interest in foot and ankle pathologies. And the reason being, I think they're very under-researched in the literature. And I've been a physiotherapist now for 18 years. And I would say probably in the last 3 to 4 years, I've taken a special love towards the foot and ankle. Some people would say it's a bit of a fetish. I would say it's just a little bit of an interesting topic and subject point. But yeah, I wouldn't say look, we've all had ankle injuries in the past or foot injuries in the past. I wouldn't say I've had a specific traumatic incident that's made me then specialize into foot and ankle. I think it's just an area that I really find overwhelming, I think. And researching about it, learning about it, being involved in it, and having a private clinic that does solely foot and ankle just open up plenty of discussion and open narratives with patients as well as clinicians.
Right, for sure. So you said the clinic that you do is only foot and ankle at this point?
I have a private clinic on Fridays, away from my NHS work, which is more what we call in England first contact physiotherapy. It's an FCP role, which is basically triaging, so no real treatment or rehabilitation as such. It's more a case of showcasing what we know and ruling out any sort of sinister pathologies and red flags. So a patient may present to you with whatever, and it's our job to then make sure that their pathway is the correct pathway, and it's that first contact, right time, right place, really, making sure they're not overdiagnosed or underdiagnosed or nothing is serious is missed. So that's what I do, and that can be everything under MSK pathologies. But on Fridays when I'm off, I tend to do a little clinic, which is, yes, I would say knee, foot, and ankle is where most of my patients come in from.
Very cool. And give us a little bit of a story about yourself, just as an individual, outside of your fetish of the foot and ankle.
I'm a happily married man. Been married for 12 years. I've got two wonderful, beautiful kids. It's my birthday tomorrow. I'll be 38 years young, as you can see
Happy
by this
birthday.
bit of greyage here and greyage here. That's the reason it's covered. And yeah, like I said, I've been in my 18th year of physiotherapy, qualified in the UK, and I've been lucky to travel the world: Azerbaijan, Russia, United Arab Emirates, and now back in the UK. And yeah, who knows where the next journey will take me? But I'm now interested in doing a bit more education things, teaching, maybe university lecturer, and a bit of private stuff on the side. But I want to get away from what we've done for a long, long time as physiotherapists. And I think that's where the profession is changing, and it will
Hmm.
ever be changing. And I think that's where we need to focus more of our attention on things like this, which are more valuable and meaningful for members of the public and also clinicians like us, young and old. Yeah, I said
We like
young
to
and old.
yeah, for anyone who isn't watching this clip, yeah, Faraz was gesturing to himself there. But yeah, I agree. It's really important, I think, to focus on the educational bit, and for today's podcast, the plan was to get into, I guess, a sort of masterclass around the foot and ankle, and just try and give people as many tools as possible in the short amount of time that we have, on, I guess, assessing and treating different ankle pathologies. So a
Sure.
lot of this is going to be guided by you, and I'll just be helping to facilitate sort of the questions.
Sure.
But did you have an idea of where you wanted to start here?
Sure. I want to start basically by saying that obviously the research for foot and ankle pathologies is quite scarce. And most of the evidence we see around foot and ankle has, at the end, when it comes to the conclusion, inconclusive evidence. More research is necessary. Okay. I know a lot of research papers have that. But when it comes to shoulder, spine, knee, there are a few more conclusive, robust evidences out there. But the foot and ankle, it just seems to be we're a little bit lost in transition. Is it or is it not? Is it about algorithms? Is it about guidelines? So I think first and foremost, people are a little bit daunted by the foot and ankle, okay? Because it appears to be a very easy joint, but I would say it's quite the contrary. It's a very complex joint, okay?
Mm-hmm.
When we're looking at around 26 bones that form up the foot and ankle, looking at over 30 sort of what we call joints of the ankle, small, minuscule joints, some large scale joints. We're looking at over 200,000 nerve endings on the sole of the foot, and we're looking at general, how can I say, soft tissue structures, muscles, ligaments, tendons, nerves, being so extensive in the foot and ankle. And it's probably the only part of the body that doesn't really get a rest because we're on our feet. Do you know what I
Yeah.
mean? So I think it's a complex joint and it can be easier to understand. But I think people, both patients and clinicians, don't understand how to maybe navigate their way when approached with a foot and ankle patient. And I think that's where we should start, really, by breaking down Mr. Noah Mandel here. Okay, and if we look at the foot and ankle, everyone's seen a model like this, whether it's an anatomical model or whether it's a Google image or a YouTube video. Everyone knows what the foot and ankle looks like. Okay, but I think when we're treating it as clinicians, I think it's really important, and I like to split it into a few segments you can call, and I just want to demonstrate that for you quickly here. So if we look at the forefoot, okay, that's called a forefoot. Then we've got the midfoot, and then we've got what we call the hindfoot. Okay, that's segmentally breaking down the foot and ankle that way. Then I like to further divide it into the medial compartment, the lateral compartment, then you've got the dorsum of the foot, and you've got the plantar surface of the foot. And lastly, if you want, you can use the posterior aspect of the ankle. So if we do that one more time, it's forefoot, midfoot, hindfoot, and then medial, lateral, dorsum, plantar, posterior. Okay, and the reason why, and people think, oh, maybe you're teaching us to suck eggs here. I think the reason that's important is if I turn around to you and said, Noah, you must have had a patient 2 days ago that presented to you in your first consultation and said, I've got a bit of heel pain.
Mm-hmm.
Now, I'm not being rude here or undermining you, But before that patient comes into your room, you've already made a diagnosis in your mind that this person may have plantar fasciopathy,
Right.
or he may have a bit of an insertional Achilles tendinopathy, right? Correct me if I'm
Right.
wrong,
Fair. Yeah.
right? So,
Yeah.
so,
Yeah.
so, so, and that's why people think, okay, yeah, it's heel pain. Oh, it's got to be one of these two pathologies. But then we think, when does our mind ever cross the potential of maybe having a calcaneal fracture, or a retrocalcaneal bursitis, or a Baxter's neuropathy, or a L5S1 radiculopathy that's kind of being focused, or let's just say the pain is focused around the calf/heel area, or somebody with a history of psoriatic arthritis who has some enthesesis, So it's like there's so much out there when it comes to heel pain, but we as clinicians just go for the obvious pathology, or what seems to be obvious, and sometimes it's not that crystal clear. And the same concept will be if I was to pick, let's pick your brain, Noah. So if I said lateral midfoot pain, so lateral midfoot pain gives us an idea that it could be something around the metatarsal, the fifth metatarsal.
Right.
Yeah,
That's
it could be
immediately where
Jones
my mind
fracture.
went to. Yeah.
Exactly. See, that was immediate in your mind. Correct. Okay.
Yeah.
And there could be some differentials, but that's sort of what it could be, some perineal stuff going on. But that's generally what we think. Or if I said to you, forefoot medial aspect. Okay. So then we go forefoot medial aspect. So we go forefoot medial aspect of the foot. What is that? Then we go what? Hallux valgus or bunion. We go big toe osteoarthritis. We go gout, for example.
Right. Yeah.
So again, I think breaking this guy down into smaller segments makes it easier for us as clinicians and also patients to understand their potential pathology. And that's what I like to do. So I want to start off with that. I hope that's kind of eased people's or listeners' minds in terms of how they navigate foot and ankle pain.
Yeah, and I think it'll be really, really useful. And I think what you said at first really it was very like a true experience for even myself. Just as I started within my first year of practice, the most daunting area for me was the foot and ankle because there's just so much going on there. And I think a lot of people can relate to that. But it doesn't always need to be so complicated. And I'm a huge fan of trying to simplify things when we can. So
Absolutely.
I'm eager to get into it.
Absolutely. Yeah, great. I mean, again, that's the same thing. I mean, we talk about a lot of stuff. There's a lot of evidence surrounding biomechanics. Okay. There's a lot of evidence surrounding footwear choices. Okay. And that's all good and well. It will benefit some people. It might not benefit all demographics. I think that's really important to make sure that people are aware of that. Yeah. Because the amount of time patients come and see us who've seen somebody else and said, I've been recommended these insoles, or I recommended this $800 footwear, for example. It's very, very common, and there's no getting away from those narratives that we may hear from other people. So I just think sometimes breaking it down into simplistic terms that we all have different anatomical variances, including the foot. And I like to use different kind of, I'd say, demographics in my explanation to patients. And I might mention people from South America who play football or soccer on the beach in barefoot, so their foot has all sorts of different biomechanics, but however, they have adjusted to the load that they need and the environment that they need. So their foot is absolutely fine. So you look at South America, you look at India, you can look at different parts of the world that may use their footwear for doing different movement patterns. The foot is adaptable, as is the spine, as is the shoulder. We can always adapt to our surroundings and load depending on how much we put through the ankle. So right. I think that's really, really important that people understand that.
Yeah, that's a good point. That's a really good analogy. I think I'm always trying to think of new ways to get people to understand that the body is resilient and that we can adapt and just making it as relatable to them as possible is key. So, absolutely. I mean, everybody can understand that people around the world use their feet for different things.
Classic example being Mr. Usain Bolt. Has a classic scoliosis, has a classic flat foot, and he is the fastest man in the world. Well, he was until about a year ago, but he's the fastest man in the world. And if you look at his feet, they're horrible. From me, looking at them, they're horrible. But for him, he's trained hard for 4 years to run 9 seconds, and he's put his feet through torment every single day of doing strength training and running and whatever he's been doing to run 9 seconds, So feet are adaptable. And I think that's important. Ankles and feet ligamentous structures, capsules, tendons, nerve supplies, all adaptable if we give it the stimulus that it desires.
Yeah, and I think another good example is LeBron James as well. And maybe not the
Good
best
idea.
example because recently he was dealing with a little bit of, I think, plantar fasciitis. So I hope
He
people
was.
don't bring that up too much. But hey, listen, 21 years in the league and still going very strong. A little bit of plantar fasciitis in that time isn't too bad. And if you look at
Longevity.
his foot and you thought, the form of his foot was everything, it'd be a lot
Absolutely.
worse than just some plantar fasciitis.
Absolutely. 100% agree with you. But yeah, so I mean, let's move on to, let's say, a pathology. So we talk about the classic lateral ankle sprain, okay, the LAS, okay, which is obviously, there is a bit of research out there. I'm not a person who is fundamentally fond of algorithms, okay, or let's say guidelines, okay. I'll tell you why, because some people frown upon that and they say, oh, well, what do you mean by that? And I think it's really important that guidelines, algorithms are helpful for some, but as my good friend Ben Cormack would say, we're positioning people into a shoebox, okay?
Mm.
And that's what we need to be careful of. I think that's what the risk is for a physiotherapist especially. We position the patient before he walks into our consultation room and you see a swollen ankle and you think, oh, that's a lateral ankle sprain right there. I know, that's a 4-weeker right there. Immediately you thought about that, okay?
Right.
But have we processed the information? Have we processed that patient's ideas, concerns, expectations, beliefs, the narrative that they've heard from their general practitioner or family medicine doctor or a friend of a friend who said, oh, I had that, that's a broken ankle, whatever it may be. So I think lateral ankle sprains are one of those research topics that, again, is inconclusive. And I've got a journal here from Bleakley and colleagues in 2021, which says most ankle sprain research is either false or clinically unimportant. Okay, a 30-year audit of randomized controlled trials. Okay, and that's just a list of 30 randomized controlled trials that go through what I said at the beginning, all the methodologies that you could use for an ankle sprain. And at the end, it says inconclusive evidence suggested. Okay, more robust evidence is required in ankle sprains. Okay, so that's where lateral ankle sprains are. There's not much research regarding surgical versus non-surgical. What are the results? What are the long-term outcomes? There's no long-term trial over 5-10 years that looks at that. And there's all these research papers about, whether it's a loading protocol, whether it's a kinesiology tape, whether it's ultrasound, whether it's dry needling or, fascial release, all these things. You can look at all these different, treatment methodologies. But ultimately it comes down to the loading principles. Okay. And that's where the foot and ankle is really important. And my biggest concern with ankle sprains is we are not training or rehabbing ankle sprains in those provocative positions. Now, people, again, find that hard to understand. We see all these hop testing. We see all these, triple leg crossover, vertical jump test, side hop test are great, but the foot is still in the sagittal plane. How do you have an ankle injury? You have an ankle injury like that. That's how you have an ankle injury. Okay. So instead of being in that position when we're rehabbing, why don't we try to rehab in that position? Now, that doesn't mean
Faraz, can I interrupt you for a second? Just for anyone who isn't watching on YouTube, Faraz is inverting the ankle.
Correct. Yeah. I'm inverting the ankle. So I'm basically stretching what we call the lateral ligament complex, which is here. Okay. So as I do that, we stretch the lateral ligament complex. Okay. I'm not going to teach you just like eggs and go through each ligament. That's fine. But as we do that, okay, now that's the mechanism of injury. So when we're rehabbing, we're always rehabbing here. We're doing some band work here. We're doing some band work here. We're doing some loading work here through the ankle, but we never really train in that position. Okay. Now, I'm not saying we should jump into those positions. I'm not saying we should be training every single movement pattern in that inverted position, but what if we were to train in that position? And that leads me nicely on to a trial that I saw, a journal that came out in 2023, actually, which is by Wagemans and colleagues, which looked at rehabilitation strategies for lateral ankle sprains do not reflect established mechanisms of re-injury. This is one of the real nice papers that come out just now. So they've really now found out that, of course, we're having recurrent ankle sprains and developing functional ankle instability and chronic ankle instability because we're training in this sagittal plane. Why don't we train here? Why don't we ask patients to walk on the outside of their toes, do some rehab there? Why don't we ask some patients to actually just drop from a small height, even if it's 2 or 3 centimeters, and drop into an inverted position? Drop and hold. So we're developing those proprioceptive measures and that somatosensory feedback that we need all the time in ankle rehabilitation. So I think that's where I would say the research needs to go. And a lot of rehab, we look at social media, we look at YouTube videos, and the people out there are promoting lots of different foot and ankle stuff. But if you look at most of it, there'll be very, very few people looking at things like training in an inverted position or an everted position, for that matter, depending on what ankle sprain you've sustained. So I think that's where my lateral ligament complex rehabilitation would focus on, and that's what I try to do in my practice. Like we talk about people with back pain,
Yeah.
the back is designed for lifting, bending, twisting, turning. So as part of your rehab, why wouldn't you get somebody who's doing some deadlifts or picking up some shopping bags from a local grocery store? Why wouldn't you get people to do deadlift? That's one of the grandest mechanisms you can do to
Yeah.
mimic what you would do generally. Same with ankle sprains. So I think that's where the research is quite lacking at the moment as to why we're getting so many people with chronic ankle instability. And after their initial ankle index sprain, people are having residual symptoms for 2 years, 3 years, 4 years post ankle inversion. And people think it's just a simple inversion injury. Get on with it, ice, ibuprofen, and 4 weeks, tape it up, you'll be back on the basketball court or football pitch, And that's what is historically treated as an ankle sprain.
Yeah, I'm a huge fan of just trying to make everyone with an injury, if it's okay with them, of course. I'm always proposing this idea to them, but trying to make them as resilient as possible. Some people maybe can't be bothered, even if you give them the advice that you think is best. But I am a big proponent of trying to make people resilient. And it's such a good point that there's so many other injuries and areas of the body where we do just naturally, I guess, take that into consideration. Someone dislocates their shoulder. You already have in mind, not on day one, but eventually we need to get to a point where we're going to train your shoulder in sort of more provocative positions. Like we'll eventually get to maybe the overhead ones. And that's just such I think, a natural idea for a lot of people.
Exactly. And that's, I've worked in sport a lot of my life. And even in sport, I was still growing up. I was still immature as a physiotherapist. I wasn't sure about the research, where it was going. And you can still see now in the elite level sport, when you see people doing some, social media clips and, you see Real Madrid and you see, whatever, you see the LA Lakers or something, you still see the Bosu ball out there, which is fine. I've got no problem with the Bosu ball. I've got no problem challenging surfaces. I've got no problem with unstable loads or unstable surfaces. Doesn't matter. But I still see people training the foot in that position there. Okay. And that's fine. Okay. So your jump test, your vertical jump test is up and down. Yeah. Your horizontal hop test is forward with a bit of a landing. Okay. But there is no even small, minuscule provocative motions of the ankle, apart from maybe, well, not even that, an eversion band. If you have two ankles and we're doing a bit of eversion movement or something. It's basic stuff. It's not in the loaded position. Does that make sense? So I think that's where we need to kind of focus a bit more. And I think that's where the research needs to spend a little bit more time on.
Can I have a quick little anecdote here?
Of course you can.
A couple of days ago, I'm seeing a young volleyball player with an inversion ankle sprain. Okay. First off, let me just say, young people, they heal so quickly. It's mind blowing sometimes. Like all bruised up the first time he came in, his ankle's swollen. 2 weeks later, he's back to doing all sorts of jumping activities. Like his jump height is even side to side when we measured it. There's so many things that he could do, feeling very confident and without pain. But putting him passively into inversion, it still bothers his ankle. So I told him, I think you're very close to being like fully 100%, but I think it still makes a lot of sense to train that position where you're still having a little bit of discomfort.
Yes, I completely agree with you. And again, there's that difference of return to training, return to sport, and then return to performance. So he's probably all good and well returning back to volleyball, but returning to performance at the highest level, where there are other stimulus around the pitch, balls, crowd, $1 million contracts on the line, or whatever it may be, they're the times that we sometimes feel, we're not right here. And then, of course, that biopsychosocial approach is also in the background. But I think you're absolutely right. And I think that's where I spend a lot of my time actually trying to educate a patient. And when they finally get it, it's actually quite relieving and quite rewarding that they actually understood what you're trying to do, especially for the foot and ankle, because people are afraid. They start wearing tapes and they start wearing bandages. and that becomes the new norm. The ankle feels a bit more secure with a bandage around it. Of course it does,
Yeah.
but those external braces can't be used forever. So it's important that we try to educate people.
Yeah. I mean, the
Yeah.
idea of bracing is let's stay away from those positions.
Yeah, exactly. Exactly. Same thing with back pain, isn't it? Stay away
Yeah.
from extend. If it hurts an extension, don't go into extension. But are you going to not go into extension for the rest of your life? No, you're going to ease back into those provocative motions and slowly start to train the spine and the lower back to go back into those positions that it's been doing for 45 odd years or however old you are. You don't
Right.
suddenly just lose it unless there's been some horrible trauma or something.
Yeah. Yeah.
But otherwise, generally get on with it, I say.
Yeah.
And then that kind of leads me nicely on to my next point. Obviously, plantar fasciitis, plantar fasciopathy, whatever word you want to use. I don't know what they use in Canada, but here I don't know what they use anymore. Heel pain, heel pain. I think
Plantar
plantar heel
pain.
pain.
Yeah.
Yeah, I think PHP, plantar heel pain. Again, okay, fine. So different parts of the world, and again, you'll have viewers from India, you'll have viewers from Slovakia, and they will have different terminologies. Okay, so it's
Yeah.
really important that we cater for everybody. So yeah, plantar heel pain, same thing, same concept. What is the underlying principle? And if we look at the study by Morrissey in 2021, and he looks at his little diagram, which you can probably see here. I don't know, you've probably come across this diagram before. And the first core principle is obviously education. Okay, education and load management. And the same can be said for Achilles tendinopathy. Those 2 points, and you've probably seen one of my posts recently. It was actually from Tom Goom, the running physio, but he made a really good post about the bubbles, the big bubbles that are meaningful and the small bubbles that don't really matter. And the biggest bubbles are education and, of course, load management. And then you've got the smaller bubbles like medication, footwear, orthoses, shockwave therapy. All these things are adjuncts that we just chuck in as physiotherapists. And again, there's nothing wrong with them. Patients will benefit transiently. They might get some benefit. Or some people will feel like, you know what, it's the best treatment I've ever had. Great. Happy days. Hallelujah. Good for you. But the research is very, very clear when it comes to that. And it is a case of shit down and build shit back up,
Right.
as Greg Lehman would say. Okay.
Yes.
And it's the same principle. It has to be done for plantar fasciitis, Achilles tendinopathy, any foot and ankle pathology that's had that acute trauma or acute overuse injury. Calm it down, build it back up again. It might take 3 months. It might take 9 months. It may take 18 months. That depends on the individual attached to this guy, not just this guy attached to the individual. Let's just say that.
Yeah.
Yeah.
So let's say you have the case of someone with plantar heel pain and you've been trying to calm it down for a long time and the symptoms are persisting. How do you go about approaching that? At a certain point, do you think like, hey, let's just load it up a little bit more? Or, what do you think?
You know what? That's a really good question. It's a valid point because there are people who come to see us and say, look, we've done a good 6 months. You asked us for 6 months. We've done a good 6 months, 3 times a week, religiously doing that strengthening, loading program, doing some plyos, starting with low plyos to higher plyos to box jumps to skips to stair runs. We've done everything that you've asked us to do. And I generally tell people when somebody comes into me and I know or I suspect a plantar fasciopathy, I give them that immediate expectation that this is a 12-monther. This could take anything up to a year to resolve. And that gives them that peace of mind straight away that, oh my God, well, that's a long time. But at least I've not said 3 months it's going to get better. Because then they come knocking on your door and say, well, you said to me 3 months with these exercises. Why has it not got better? So then it begs the question is to say, is it the correct diagnosis? Is it indeed plantar fasciitis? Is it something else? Is there some calcaneal issues going on? Is there some, fat pad atrophy? Is there something else? Is there Baxter's neuropathy? Is there something else going on that could be delaying this outcome? And that's obviously where I'd go down the route next. And of course, if it's a true plantar fasciopathy, it hasn't worked with loading program. It hasn't worked with your plantar fasciitis fighter program. It hasn't worked with load management. It hasn't worked with footwear, shockwave, to some extent, acupuncture, whatever you want to put in there. You may need to consider other avenues for treatment. Now, of course, it gets a bit more invasive then, doesn't it? It gets to the point where, people have tried for 12 to 18 months of loading and it gets to the point where what do they need to do? And then sometimes you can open up the avenue for injection therapy. I wouldn't inject a plantar fasciitis. I just wouldn't do it because of the risks involved with plantar fat pad atrophy. So that's the biggest risk factor of injecting a plantar fasciitis patient. I know people privately would do it because they get paid $400 for it, or £200 or whatever you want to call it, in whichever currency you want to use. There are some private people who say, yeah, we'll give it a go. 1 injection is not going to matter. 2 is not going to matter. And all of a sudden you get this plantar fat pad atrophy, which is really, really debilitating. And then you get people who go down the surgical route. Again, I've not had many patients in my 18 years. I probably had one that's had a surgical intervention and probably regretted her decision. Quite dramatically, and it was in persistent pain for probably 4 to 5 years post-op. So
Oh my gosh.
it's one of those catch-22 situations. We have to really be careful when we talk to patients about these expectations, especially in invasive procedures like injections and surgical interventions.
Mm-hmm. I'd like to get into a little bit of fat pad atrophy, but before we get into that, we are talking about a bunch of different areas of the ankle and the foot, and how to sort of going about figuring out what's going on in the foot or ankle. So I think a lateral ankle sprain for most physios is pretty self-explanatory with how you would go about diagnosing that.
Yeah.
What are the key things that you need to rule in a true plantar fasciopathy or plantar heel pain, plantar fasciitis, again, whatever you want to call it?
Yeah, whatever you want to call it. Yeah, fair enough. I think the best ruling in point that you have is your clinical history. I know people talk about that a lot with back pain. What happened? So I think that subjective examination, when somebody comes into your room and they tell you the first few steps in the morning, those first 10 steps to the bathroom are absolute agony for me. Okay. So again, that might give you that indication that, okay, it could be a fasciopathy going on here, or some form of opathy or tendinopathy, whatever word you want to use. But that's what even Achilles tendinopathy, for example, will be the same thing. First few steps in the morning. I think in terms of moving forward with your diagnosis, and obviously clinically, it's very easy to push somebody's medial tubercle and the calcaneal and say, oh yeah, that's it, and then scream. Okay, and you can kind of diagnose that. But of course, your other screening questions, your calcaneal fractures, obviously make sure they're ruled out. The red flags, make sure they're ruled out. You've had no recent history of falling from a high height, a scaffolding or a ladder in the last 2 weeks, for example. Yeah, no, there's been absolutely no trauma. Fine, good. Any sort of other nerve-related neurovascular concerns into the feet, numbness, pins and needles, tingling, burning sensations into the feet? No, absolutely not. Okay, so we can rule out Baxter's neuropathy potentially. So then if we go to fasciopathy, plantar fasciitis, if you really want to pull out your small, flashy ultrasound, if you've got one in your clinical practice, why not? If you want to confirm your suspicion of a little bit of fat pad atrophy or a little bit of irritability around the plantar fasciitis medial tubercle or directly under the heel pad, or a heel spur, for example, or an x-ray. I mean, again, if you have a heel spur on x-ray, we all have a heel spur on x-ray, to be honest. We're all going to have an asymptomatic heel spur on x-ray. But patients sometimes want that reassurance, which I understand as well. So I think once you've done your clinical examination, your clinical history, and you are 100% sure, or at least 95% sure of your diagnosis, if you want to confirm that diagnosis, there's no harm in getting an x-ray to rule out any sort of bony injury. If you do suspect any trauma, but if there's no trauma, an x-ray is not going to show you anything. So I would say my go-to imaging would be an ultrasound, a diagnostic ultrasound, to see what is happening, where the inflammation is, are there any hypervascular areas, to see then how we need to manage this. Is this just a case of time and patience? Is this a case of, it's got too bad, now we need to try some intervention, a steroid injection or PRP or whatever that may be? Or do we need to go down, this has been too long now, that plantar fascia doesn't look really how it should do on imaging. You've tried all your loading, tried all your activity modification, tried all the treatments under the sun, off you go to the orthopedic surgeon for an opinion. Again, but that comes down to the informed decision-making and the shared decision-making that you, as a physiotherapist, would have told the patient and said, look, these are the options. And I'll be honest, I usually give my patients 4 options. Okay. 1, wait and see, do nothing, leave it alone, get on with it. Number 2, aggressive, or should I say self-empowerment in terms of physiotherapy and rehabilitation, actively involved in your physiotherapy and your journey. Number 3, we can explore imaging and some injection therapy if we need to. And number 4 is an orthopedic opinion. And they're the 4 very, very easy tools, or should I say pathways, that we give patients, because then immediately when you turn the orthopedic surgeon, no, I don't want to do surgery. I don't want to do, and immediately one's eliminated. It's quite nice, and then you're left with the other three. And most people, if they're sensible and have made that shared decision-making process, will always choose number two and always will say, you know what, no, I'll give it another go. I'll work on my lifestyle factors. I'll work on my footwear. I'll lose some weight. I'll stop smoking. I don't know. I'll do whatever I need to do to try to avoid surgery. And that's kind of what our job is just to educate them on the correct lifestyle and choices, making the right choices.
Yeah, absolutely. That was great.
Yeah.
All right. So when it comes to the imaging there, you know, do you always give people that option? Or no. Okay.
In my role as a first contact physiotherapist, imaging is not even discussed really, unless there has been some acute trauma.
Mm-hmm.
You know, if there's been some acute trauma, if somebody fell from a scaffolding and landed directly on their heel had a horrible, let's go immediately to A&E and let's get you an X-ray. That's the referral pathway we would use. But if somebody has got, 6 months of plantar fasciitis, have done no active rehabilitation, they said, oh, we've got some stretches from YouTube that we've been trying, or my uncle's sister's dog told me to do this one. I've been doing this heel drop on the stairs for every single morning, 10 seconds I've been holding it for, so this, that non-guided, non-supervised, no real progressive loading or graded exposure at all. And they've had it for 6 months and they've just gone with it. And for someone to say they've just gone with it, it kind of means that it's not very serious. Do you know what I mean? I mean, it's not really, is it?
Yeah.
If people can get on with it and live their life and go to work, come back and have pain in the morning, but then gets better with movement. And at the end of the night, it gets a bit sore and they can pop a couple of ibuprofen or whatever it may be, naproxen, and it kind of calms down. If you give them that information, say, look, guys, try this approach. Try the plantar fasciitis fighter. That's the first thing I say. Try it and invest in it. It's going to cost you 10, 12 pounds. Use it 2 to 3 times per week if you want to use it every day. Low dosage, low frequency. See how you get on. So my imaging is not discussed at all in my first consultation unless I suspect something sinister.
Mm-hmm.
Or if somebody comes back to me and has seen 4 or 5 physiotherapists and they've done the correct things that I would expect them to do, and they have given it a go with activity modification, load management, whatever you want to call it, and it's been now 12 months, you may think, you know what, if you've got private healthcare insurance, why not? Go get yourself an ultrasound scan and let's see the depth and see what's happening at your plantar fascia. If it is indeed the plantar fascia, is it a fat pad? Is it neighboring tissues, soft tissues? Is it calcaneal erosion? What is it going on? And that way, then they, again, peace of mind, really. And when it comes back with plantar fasciitis, they kind of just shoot themselves in the foot sometimes and say, yeah, okay, you were right, and I just got to get on with it for another 12 months until it gets better. Because plantar fasciitis, like tennis elbow, does have a good, favorable natural history. It does.
Mm-hmm.
And it will get better without any intervention, just load management. Even without the loading program, it will get better. But it's a matter of time, right? You might get that 50-year-old woman who's going through menopause, hormonal imbalances. Oh, hers is going to be a bit longer, or she might be on HRT, hormone replacement therapy. So hers might take a bit longer than somebody else who's not on those medications. So it's building up that clinical picture to help you clinically reason and make that correct decision, I think.
Got you. Yep. So that we spoke about differential diagnosis very briefly there, and obviously ruling out like a calcaneal fracture versus plantar fasciopathy. We discussed that, right? If there's trauma, that's how you rule that out. If there's any neuro involvement, probably do some peripheral nerve testing, screen out the spine as well.
Correct.
How would you differentiate between plantar fasciitis, heel pain, and something related to the fat pad?
Good question. Fat pad, it depends on the you'll see when you see fat pad atrophy, it's almost like when you got your Dupuytren's or you got some carpal tunnel and people have lost that thenar eminence, is really, really wasted away. And you will clinically see it in somebody and their fat pad, and you look at the shape of a heel, you can see the shape of the heel, it's quite big. On top of that calcaneus, you've got a bit of a fat pad, and you've got on top of that the fascia, the fat, the muscles, the skin, everything's on that. It becomes quite a bit of a fat heel, okay? When you look at both sides, when someone's lying prone and their feet are hanging off, you'll be a bit delusional to miss a fat pad atrophy, okay? Because you can actually clearly, really visibly, clinically see that somebody has got a lot of wasting on the medial tubercle and you can always feel the bone on the affected side compared to the non-affected side is really, really protruded, if that makes sense, because there's been a loss of that heel pad. And again, like I said, I don't think there's any magical way to determine fat pad atrophy to plantar fasciopathy. I think it's literally on your experience, number one, and of course your clinical viewpoint. And if you want to have some ultrasound to confirm it, then fine. You might have a third kind of piece of evidence in your armory to make that informed decision. But honestly, I've seen in 18 years, I've seen probably 4 to 5 clinically significant heel pad atrophies, and most of them have had some form of injection therapy, some long-term use of steroid, or have been on some long-term use of antibiotics for a period of time for some form of chest infection or urinary tract infection or something like that, and they've used it for prolonged periods, which has then subjected them and their body to have this reaction to some form of either tendinopathy or fasciopathy. And it's usually in those 5 patients, I would say 4 of them had long-term use of steroid injections into their heel.
Interesting.
And so it's again, I've just finished my injection course about 3 months ago, so I can inject joints, and plantar fasciitis was one of them. But they teach it on the course, but then they advise us against it because the research isn't very robust. So again, that's the problem all over the world, I think, with just universities. They teach us things and then they say this doesn't have to carry the best or strongest robust evidence. So I can safely say, as a foot and ankle person or somebody who really enjoys foot and ankle pathologies, if I was to go into a real specialism of diagnosing through ultrasound, and I saw somebody with a fat pad problem or a plantar fasciopathy, I still would be very reluctant to offer them that line of management. I would rather them go and do somewhere else. I don't really want to be held responsible for something like that. I have to be honest. It might help the patient, but I think the risks outweigh the benefits there when it comes to that. So I would stay away from, other foot conditions, Morton's neuroma, for example, does quite well with the steroid. There's a bit of research that says it does quite well. Big toe OA, osteoarthritis, or gout can sometimes benefit from steroid injection. Does all right. I think Achilles and what we talked about, plantar fasciopathy, I think I'd stay away from them if I could. Achilles, there's a high volume injections which you can use, which sometimes do a good job in terms of separating the paratendon from the tendon. Gives you a little bit of a kind of a bridge and allows the tendon to glide a bit more smoothly. People have benefited from that. Those thick, grotty tendons that you might see that are double the size of the other side, they may benefit from having a little bit of a high volume injection. But again, the research is still prolotherapies out there as well. There's so many different avenues, but I think there's no right or wrong answer. It's, again, I come down to the same thing. It depends on the patient in front of you. What are their needs? What are their expectations? Are they an elite level athlete fighting for their next $1 million contract? You may offer them some solutions. If it's Auntie Doris who's 74, just needs to walk to the grocery store to pick up her vegetables and a newspaper in the morning, leave her alone. Just ask her to modify her activity and send somebody else to get a paper or something. I don't know. Do you know what I mean? So I think that's really important, to look at that patient and understand your patient before you make all these clinical decisions and pathways.
Especially ones that have potentially a higher risk as well, right?
Exactly. And obviously always bear in mind those risk factors. And as obviously, we missed on one point I want to just talk about. We talked about how would you differentiate things like fat pad atrophy, how would you differentiate things like plantar fasciopathy, how would you differentiate, for example, spinal masqueraders that could be causing an L5-S1 radiculopathy, which sometimes refers down into the calf, into the heel, and people get some numbness, pins and needles tingling into the heel, inability to calf raise. People think, oh, it's an Achilles tendon rupture. But is it? No, it might not be. It might be coming from the spine, and that's something really, really important that we need to know about. Is it an inflammatory disorder? Is it inflammatory back pain? Or is it inflammatory arthritis, psoriasis being one of the ones that's come up to 50% of the population sometimes have some form of what we call enthesitis. So, you've got to be in the back of our mind, always be thinking these things, because every person that walks into your room, for me, has a red flag. It's just, someone could have a red flag, and you have to always think that, okay, what's this patient got in front of me that could be a red flag? We talk about the yellow flags, the psychosocial stuff, fine. But if somebody comes up to you and says that, I woke up in the morning 2 days ago and I tried to go on my toes to brush my teeth, for example, because the physio told me to do that and I couldn't initiate the movement in my right heel. I just got on with it. And okay, I want to investigate that a bit more. I want to find out what's going on. How has that happened so suddenly? Have you had any history of back pain? Oh, yeah, I did about 4 years ago. There was a bit of trauma to my back. So it's really important to build a picture. And in my role in the NHS, that's what I get a lot of chance to do, is screen these individuals who've not seen their general practitioner or family medicine doctor, who've come in to say, I've got heel pain, and I fell from a horse 5 days ago, landed directly on my feet. Okay, fine. You start building a picture. This doesn't sound right. There's a bit of swelling off my heel. Can't put my footwear on. Except I can't go up the stairs. And you start thinking, okay. And did you do any imaging? Did you go to A&E? No, I didn't go to A&E. I did no imaging. I just thought I'd come and see the GP. But the reception told me to see the physiotherapist because it's heel pain. So then you need to make that clinical decision to say, okay, 2 weeks of heel pain, traumatic heel pain. Let's get you referred out for some imaging to rule out any sinister pathology. So I think there's not many sinister pathologies of the foot and ankle. I'd have to say that. Most of them are those sort of longevity type injuries that take time to heal because it's such an intricate part of the body, like the hands, superficial joints, you can feel everything. I think that's probably the dilemma people face, that, it's a foot, traumatic incident, we got to get it x-rayed. It's not all the time, fifth metatarsal fractures, for example, not all of them need, or stress fractures of the foot and ankle, not always do they need imaging, but sometimes they can help rule in things that we would sometimes miss on clinical examination.
Mm-hmm. Yeah. I love what you were saying before about just having a very detailed history and considering red flags, because always the top priority is just making sure that the person is safe. And then after that, making sure that they're on the right pathway. Yep. And it's, even though we're talking about the foot and ankle, we spoke about back pain and we spoke about arthritis and we spoke about, neural involvement. So there are other things to zoom out and focus on.
Exactly. And that's the thing. I would say that I think that's for any young listeners, any young physiotherapists out there who are listening to the podcast, even senior clinicians, I would say, I think that should be on your radar that, it's not just MSK pain. It's not musculoskeletal pain. And it's not just biopsychosocial pain. Okay, so there's two elements right there. You've got your neural masqueraders, your neurological conditions. You've got your inflammatory conditions. You've got your vascular pathologies. Claudication, for example, vascular claudication or neurological claudication can affect lower down the body. Your diabetic neuropathies, for example. So there's so many things out there that can mimic foot and ankle problems. But again, most of the time, like I said, 85, 90% of the time, it's an ankle sprain. It's a Liz Frank injury. It's a big toe osteoarthritis. It's a bunion, most of the time. And that's why people think foot and ankle is boring. You know what? Sometimes it can be boring. But there are those interesting cases that you do get, for example, that you think, that was really interesting. And I'll tell you what, while we're here, you're Canadian. I mean, you're not American, but you're Canadian. But you've seen, obviously, the NFL recently, the two quarterback injuries. It's really interesting how a quarterback, 39, Aaron Rodgers, and today, what's his name? Kirk Simmons. What's his name? Kirk. Sorry. Forgot his name. I posted today as well about it. Forgot his name. Anyway, today, yesterday, Kirk Cousins. I said Kirk Simmons. Sorry, Kirk Cousins. Kirk Cousins yesterday ruptured his Achilles in the middle of the game, in the fourth quarter, actually. So again, and he's 35, quarterback. Aaron Rodgers, 39, quarterback. And it's really interesting, both non-contact injuries. And you ask yourself, these are elite level athletes. Unless they've had some long-term steroid use that we're not sure about, from their clubs have been administering them, or they've gone privately for these injections, or long-term use of antibiotics. Why at the age of 35, 39 would you expect Achilles tendon rupture to happen maybe a little bit earlier? I don't know. In that level of high-level sport, in the normal population like us, the research says between 40 and 50 males get their sort of Achilles tendon ruptures, but so I don't know what's going on at the moment. That's really interesting because Aaron Rodgers was 7 weeks ago and Kirk Cousins was yesterday, actually. So I'll be interested to see how he gets on because I posted about Aaron Rodgers saying that was the end of his career, and I was wrong. I was definitely wrong because I thought 39, NFL, quarterback, you're done for. That's it. Achilles rupture, but he's had a speed bridge procedure, which I didn't know much about, and I've gone away and read about how they encroach the Achilles and how they pull it through with pulleys. He's 7 weeks and he's on the pitch throwing the NFL ball. And I'm thinking, wow, that's
Yeah.
impressive.
He wants to
Really impressive.
he wants to break the record for quickest return.
He does, doesn't he? I mean, 7 weeks and
Yeah.
he's on the pitch and he's literally doing, you see it. I posted it today. He's doing
I saw
some
him throwing, yeah.
small side steps and just throwing, and then we threw back pedals and threw side steps. And I'm thinking, 7 weeks. I know people who 7 weeks who are still in a freaking boot, you
Yeah.
know,
Right.
still in a aircast boot or a vacoped or whatever you want to call it, and they're just kind of getting out of the boot and doing a little bit of alphabet writing and a bit of
Yeah,
toe
yeah.
pitching. And so I'm thinking that's really interesting, and how people can come back from sort of really, really career threatening injuries for me. And that's what makes my job quite interesting. I really enjoy
Yeah.
those, malleolar fractures and tib fib compound fractures and Achilles ruptures, and how people can get back from those with the psychosocial barriers in place, but also that drive and determination to get through their pathologies, to get back to the highest level. I get to have contracts to play for, but honestly, I don't think I could do it. Because I don't have that drive. But yeah, really interesting.
Yeah, it makes you really appreciate just how resilient and how impressive humans can be and how much they could overcome sometimes. And I think it's important to keep those anecdotes and those stories in the back of your mind so that
100%.
accurately, you can inspire hope into other people.
100%.
And it's
I just want to
not a
say that
fantasy.
I think it's I think you're absolutely right there. And I just want to say that I think clinical research, evidence-based research in medicine or evidence-based physiotherapy is really important. It's our kind of backbone, you can say. Okay, but it's not always right. Does that make sense?
Yeah.
Like, it's not
Yeah.
always that we have to base every single clinical decision, because the research says this is what I did. Because I know, and I would have done the same thing with Aaron Rodgers. If he was here, I know he would have been in a boot for 4 to 6 weeks. And, depending on the surgeon's protocol, I would have kind of eased him out and, increased or decreased his heel depending on how his recovery was going. And I would have, then rehabbed him slowly and back to full. But there's always going to be an anomaly out there who
Yeah.
will prove the research wrong, who will prove you wrong as a physiotherapist. Say, look, I can do this. I don't
Right.
sod your research. I don't care what your research says. This is what I'm going to do. And that's why I say to people, I think clinical research is good. It's our cornerstone. We should always have that in the back of our mind to guide our treatment pathways, and our clinical decision. But sometimes I say, you know what? Don't worry about the research. Look at the patient in front of you. And if they can do it and they believe they can do it and those expectations are there and they have that firm belief structure, then happy days. Support it within reason.
Yeah.
Absolutely embrace it, I would say.
Yeah, I agree. And it's like what you were saying at the start about the Bleakley review, where
Yeah,
there's a lot of issues with the research out there. And
a lot of
again,
research.
that's not advocating to make everything the Wild West and that evidence doesn't matter and that
Sure.
you could do everything just like willy nilly.
Correct.
I can't believe I said willy nilly just there. Anyway,
That's an English word. Good man. Well done.
yeah.
You're learning.
You're rubbing off on me, and I don't like it. Yeah, but I think the first thing you have to consider is what I'm doing very risky. If that's the case, probably don't do that.
Refrain from it. Yeah.
Yeah. But hey, does this have potential in helping someone? Then go for it. And at the same time, probably don't come up with crazy mechanisms as to why these things are working when you're explaining them to people. I think as long as you're not spreading misinformation and the person is safe and they're not wasting their time, then you don't always need to be completely in the realm of evidence.
Absolutely. I think I completely agree. And it's really important that we use analogies with patients. I think that's what I've learned in my clinical practice. I think using analogies with patients, whether they be small anecdotes, small stories, or literally small little references that we can use, I think really helps patients understand and make that decision according to these little analogies that we may use. And I think that's really important. I think I'll go back to Ben. He mentioned about snakes and ladders being regarding rehab, for example. When your rehab is a long journey, it's like playing snakes and ladders. You may roll a dice and hit one and you move not really far forward, and then you roll a one again and you keep rolling ones and you get demoralized because you're not really moving forward, and then all of a sudden you roll a 5 or a 6 and you move forward with your rehab. You think, yeah, great, amazing. And then you go up a ladder and you roll a 1 and you hit a snake and you come back down again because you've had a bit of a setback. That happens. That's rehab. And that's the same with any lateral ankle sprain, Liz Frank injury, metatarsal fracture, calcaneal fracture, any pathology of the foot and ankle you want to use. There will be setbacks, and there will be days where you feel like, you know what, I don't want to do the rehab because it's painful. But I think that snakes and ladders analogy is really important in rehab. You've got to keep going to get to that end goal, and along the way there will be some setbacks. And I think if that's clear and that discussion has taken place during some of your consultations, then the patient can't really hold it against you, and they're happy to work with you on that journey.
Yeah. Ben's great. I had him on, and it was such a great
He's too good.
But yeah,
he's too good. I hate him because he's really good. but he's one of the most helpful people out there. He will pick up the phone, or you can pick up the phone and send him a message on WhatsApp, and he will take out the time to either give you a call or at least send you a voice note and reply to your concern. And when you talk to him, he gives you, every time I speak to him, which is not very often, but I do speak to him sometimes, he gives you a little pearl, a little wisdom, a little bit of wisdom. I know he's old and grey, but he's got so much wisdom. He's like a silver fox. He knows little pearls he gives you, and they stick in your mind. And, he's really, really helped me with my clinical reasoning and thought processing skills with some of his one-liners. So, yeah, hats off to Ben. Really good.
Yeah, me too. And, I mean, I only spoke to him that one time, but that snakes and ladders analogy is really good. I often use a similar one, the stock market analogy, and I work in the financial district in Toronto, so it often hits home. But I probably should stop using that one for the teenagers that come in. I'll probably use the snakes and ladders one instead.
Snakes and ladders is a good one. Trust me, it works really, really well with people, especially when they're in pain and they're trying to move and they feel like they're not getting anywhere with the rehab. I think that's a real good analogy. But yeah, did you anything else that you wanted to touch on in terms of pathologies, or I think we kind of covered everything, I think. I mean, there's loads, of course. We could be
there is loads, like who knew that we couldn't cover the whole foot and ankle in an hour? Especially when we're talking about snakes and ladders. but I guess I'd ask you, is there anything else that you feel like is really critical to talk about? We didn't talk too much about forefoot. Like we mentioned big toe OA a couple of times and bunions, but
I mean, if I was just run through quickly, I mean, again, I don't want to teach you to suck eggs, but obviously if you look at the forefoot, again, I always talk about the big toe because that's one of the first things what runs through our minds when we think about big toe is always got to be a bunion. It's going to be some form of hallux valgus. But always remember big toe OA is there. Always remember your gout potentialities. Obviously needs blood tests to screen that as well. And some special bloods can obviously confirm that. And obviously some medication can control that. Of course, look at your, small little hammer toes, little hammer toes that can happen, or we call bunionettes where you get a bunion on the outside of the baby toe. Lots of things. You got your third and fourth space in the foot. We've got your mortons neuroma that usually accumulates here, either the third and fourth or fourth and fifth metatarsal spaces. You've got your Liz Frank injuries, which is the dorsum of your foot, which is quite an underdiagnosed injury actually. So be careful when in with the top part of the foot pain, dorsum pain. That's always quite a nice one to look at. Obviously, your fifth metatarsal fracture, your cuboid fractures, your navicular fractures, your cuneiform displacements. Very, very rarely do you get these injuries, but it's important because sometimes when someone drops a heavy load or a bag of cement on their foot, a builder, for example, and it can happen. It can happen because they are quite sensitive, these bones. Okay, because it's quite, the skin is quite, the superficial layers of the bone are quite there, evident to see. Talus fractures, posterior ankle impingement, so your os trigonums. Make sure they're very common in ballet dancers and gymnasts and things like that, with all that pushing off phase. So a lot of posterior ankle impingement. Your calcaneal fracture we talked about, retrocalcaneal bursitis. Obviously, if you go further up the leg, then you've got your sort of tibia, your medial tibial stress syndrome, your syndesmosis injuries, your bimalleolar or trimalleolar fractures. The list goes on. From this plate down, the list goes on. It probably can name 200 pathologies just sitting in this guy here, know, and I think it's really, really important. And again, like I said, they might be sitting in this place, but they could be referred from somewhere else. They could be, like I said, we talk about neural, inflammatory, vascular, so many other causes that could be mimicking around this area here. So yeah, guys, I'd say just enjoy the foot and ankle. It's a marvel, honestly. There's so much going on down there. And it's really, really interesting. If you have if you have an interest in it, get in touch. I'm happy to discuss, talk. Why not? People have asked me, are you going to design a course? A lot of people ask me that. Are you going to design a course depending on your way of thinking? Because my way of thinking might be different to the classic lateral ankle sprain, for example. So try and come up with a course that makes us think outside the box a little bit. How we can engage the brain chain ankle sprain, what I talk about all the time. How we can engage that person with his ankle or her ankle. So yeah, it's something I've thought about, and I think maybe if I can do a little bit more research around the ankle, get a bit more confident in it, learn from other people, who knows what happens? I might be coming to University of Toronto and teaching there
That was
one day.
good. Very good.
Was I good? Was I
Yeah,
good?
it was actually. Yeah,
Was I good?
it was
Yeah.
like
I was there.
I could tell you were trying very hard, but it was good.
It was good though. It's worth a try, right?
Yeah.
I used to be quite good, but it's I used to know quite a lot of things. Guys use tomato and water and garbage and all this sort of stuff. It's
very good.
Yeah.
Yeah.
I know you're. Yeah. Ask if the Queen's English or the King's English. I don't know how to look at it now.
I guess I just want to add something to summarize. We spoke about how things don't always need to be so simple, but also, how sometimes things are very simple, but at the same time, 200 plus pathologies that you mentioned.
Yeah.
There's a lot going on, but as long as you've ruled out red flags, I think in many cases, and please correct me if I'm wrong here, but a lot of the times we could just go back to what Greg says, calm shit down, build shit back up.
Absolutely.
Oftentimes there's not much of a need to complicate things beyond that. What do you think?
I think you've hit the nail on the head, and I don't need to elaborate on that anymore. And I think that's the whole musculoskeletal system can be treated that way if we allow it to. If we allow it to rest, recuperate, regenerate, rebuild, whatever word you want to use. But of course, everybody understands, even we as clinicians understand that if you're in pain, okay, we move differently. We protect areas. We're fear avoidant. That's in human nature. It will happen. But as long as we can break that mold pretty quickly, rather than become the new norm, which it becomes a new norm for some people. And that's when they find it difficult to break that cycle. And then it goes into the vicious cycle of pain, stiffness, leading to weakness leading to depression leading to XYZ. And then we go off on the tangent, and then we start thinking, how are we going to get this patient back? Because this is not a structural problem. This is a biopsychosocial problem. Do you know what I mean? So I think you're absolutely right. Calm things down, build things back up, and use that analogy for the foot, the ankle, and every other MSK pathology out there.
Right. And take a good history, because sometimes based off the history, you might say, you know what, I don't really need to calm things down right now. We could just start building. Other times it's history, maybe all you need to do is calm down a bit.
Like they say, I think Ben says it and Adam says it, Mehmet says it, is history is the most important thing. Yeah. And they're telling you the diagnosis. Just listen. We have 2 ears and a mouth for a reason. Less of this, more of this. Just listen. They're telling you the diagnosis. You just have to reassure them and tell them the correct pathway at that moment in time. And, you might get it wrong sometimes, but as you get more and more experienced, most of the time you'll get your pathways correct. And as long as they have that reassurance and that trust in you, that patient rapport, therapeutic alliance, most patients are really, really happy with physiotherapists if they just give them. And if you don't know the answer, just say, I don't know the answer, but you know what? I'll find out from somebody who does, and I will get back to you. People respect that a lot more than you faffing around books and trying to get your way out of a corner, because it just looks like you're trying to get out of dig yourself deep. Yeah, you're trying to dig yourself deeper and deeper, and there's no way out. So just say, I've never come across that pathology before. I've never come across those symptoms. That's really interesting. Throw the ball in their court, and they will obviously they'll be kind of reciprocating, and they'll say, okay, this guy listened to me, and I've been to so many doctors and they just dismissed it, but this guy actually listened to me and he's going to go and find out. And it's honestly communication, clinical reasoning, and critical thinking makes you a good physiotherapist.
Yeah, much agreed. I think that's a perfect place to end off on. Faraz, anywhere that people can contact you or learn more from you, where
sure
people find
you? I mean, Instagram is probably my main platform that I use. I don't really use Twitter that much, or I use LinkedIn, but that's more for professional networking. So I think Instagram at the Farazzled Physio. I'm sure you'll tag me in this podcast. Happy to reach out. Happy to have questions. I do a couple of question answer sessions every so often. So if you have any questions, obviously I do say it very clearly, make a disclaimer that, I can't offer advice really via SMS or via private messages, because I've not seen the patient clinically. I don't know what's going on behind the scenes. I can give you a viewpoint and maybe a direction, but I can't really offer you clinical advice because that would be a little bit difficult for me to do via Instagram. But I'm happy to answer questions and network. And yeah, if you have any sort of further podcasts or questions or workshops and stuff, I'm happy to be part of those. No problem at all.
Awesome. Okay, Faraz, thank you for sharing your wisdom. That was great. Well done.
I hope that helps, Noah. I hope that wasn't. I hope I haven't complicated you. I hope I haven't complicated things too much, and you're not going to be confused with your patient tomorrow morning who comes in with a.
Listen, I'm just going to be, I think, after this conversation, more open-minded, not necessarily confused and overwhelmed, because again, the guiding principles are the same.
Yeah.
But I'm going to say maybe there's something else going on here that isn't just plantar fasciitis. So
honestly, yeah, not every heel pain is plantar fasciitis. Yes, that is where we will end on that. Can I get a picture of us two? Is that you right?
Of course, yeah.
Cool, let's get one. I don't know how we're going to do this. I'll do it up on the side. I'll do it like this. Okay, here we go. 1, 2, 3. All right, one more time just in case. 1, 2, 3. Yeah, good man. Pleasure, Noah. Well done, mate.
Pleasure.
Can I just say, you are doing a great job. I've always said that to you. I've always sent you some messages personally to say, listen, you're doing a great job as a young, innovative physiotherapist who's coming into the market, really putting your stuff out there and challenging the evidence, challenging the gurus, you could say, challenging what you've learned at university. Keep up that good work. Keep up that passion for learning. And you are one of the most growing physiotherapists out there. And I think, hats off to you for conducting these podcasts. And yeah, the future's really bright for you, mate. So keep up the good work.
I appreciate that. Thank you, Faraz.
All right, buddy. Take care.
All right.
Have a lovely afternoon in Canada. Cheerio, mate. Bye-bye.
Cheerio. Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.